Okay, I'll just a couple of things. Not no great shakes, but let's have a look at okay. Tennis and golfer's elbow. Yeah, this was unusual. I'm hoping I had a look through this one, but this is a quite thick-looking common extensor origin. Not an amazing video, but I should go into. This is short axis, quite bright. This is the muscular tendinous junction for the extensor carpi radialis brevis. Has that distinctive appearance, and it comes up, and you see it oblique, slightly oblique like this, and it's all of this. You see it, a bunching of this muscle. It forms this distinctive V shape within the muscle when you're in short axis scanning. And you come up, and you can see there it changing, becoming tendinotic.
John, is that an intra? Are we looking at that tendon, that V-shaped tendon within the fascicles? Can you give me the perimeter of the ECR or the ECRB? It's that whole area there. And
yeah.
Okay, so what is the one above it? I know that's I should know that. Is that?
I should as well. It'll be the extensor.
Okay.
Digitorum.
Okay, I'm with you. I'm with you now.
I don't ever remember them, but you just know that you're looking for that V shape, that subtle divide between the two parts of the muscle. I've not really imaged there, but there's ECRB and ECRL.
Okay.
And when it comes up here, this is supinator here, I think, and this is, but this edge has a very distinctive appearance. As you follow it up in short axis, it has this sort of V shape, pointing or arrowhead there, and it looks like when you first see it, you just think it's this, but it's actually all of this. That's the tendon is forming quite far back into the muscle.
The common extensor tendon is forming amongst all that.
This is just the tendon of ERCB.
Okay.
The carpi radialis brevis, which is thought of as the main, and often is the main problem within a tennis elbow. And you just see that thicken up there, that tendon forming up there. So this is still muscular tendinous junction, but the bulk of the tendon is here. A bit like there are a couple of other ones that do that. The semimembranosus has this tendon and everything joining in. And also long head of biceps higher up is a tendon laterally, and the fibers are coming in from the side, forming up on it.
You are indicating that the tendon is this darker color, and you are is presently the fibers pathological or effused, or is this just anisotropy that you're just
probably mostly anisotropy up to here, but there it becomes abnormal, so possibly a bit further down. Sometimes these are traveling obliquely because it's lots of fibers going in different directions, and I'm following the V essentially.
All right.
If I was more precisely on here, then you'd be able to say, but that you can see how it suddenly expands. There.
Yes. And you're saying that expansion remains ECRB and not any part of the extensor muscles above it.
No, you see how your eye follows those fibers as you go through.
Yes.
It's the continuity.
Yes.
If you look at the dots inside the muscle above it,
yes,
they're actually traveling this way. So they're not forming up on that.
Yes.
Yeah?
Yes. I can see that they're not synergistic to that they're actually getting away from or moving away. I'm with you.
Yeah. So that's quite quite a nice example when you look at it in detail of
What
a classic tennis elbow.
What do you make of it? Is it larger because of thickening? Is it larger because of a retraction mass? Is it larger because we just don't know?
No, it's tendinosis.
Okay, it's just fluid within the fibers, and we get capillary action filling the size of that.
Yeah, if it was retraction, you wouldn't see it go all the way onto the insertion there or onto the origin there.
Tell me where you are saying where's the actual enthesis start and where does it end? The attachment.
That's probably the enthesis there.
Okay, all right.
You go back into the short, and it's that area there. Yeah.
Yes. Yeah.
And you see that ropey, patchy appearance that you saw in short axis as well. But the odd thing, that's not the odd thing about this one. The odd thing about this one was what the other side looked like. The other condyle, epicondyle. You don't often see a golfer's elbow quite as marked as that on the same patient. Idiopathic.
Yes.
She had elbow pain, both sides. Not a good pattern for it, just lots of pain all around the elbow. And it was like, oh, you got a bit of tennis elbow, but you got some pain on the other side. I'll have a look at that. Oh, you've got golfer's elbow. So quite marked, bilateral. But not bilateral, both sides of the elbow.
Yeah.
I don't think I've ever seen that before.
A rowdy child that she's attempting to manhandle over and over and over.
Well, you wonder, but it was. So I actually had a quick look at. She denied any other problems in any other joints, and there's not really much going on at the enthesis. But I did think quite hard about what medication she was. I looked closely at her medication. I couldn't see anything that might be underlying it.
Would you have scanned her contralateral side for this, or were you just looking at various ground substance or
I looked at the other side. I questioned her about things like her Achilles, but she denied anything, and I didn't look because there's the limited amount of time and energy to undress patients further. But,
so did you put any injectate into either one of these, or what did you end up doing?
No, I asked our Shockwave people to have a look.
You were going to have me bootleg one of them suckers into here to let me try doing it, John. I
don't know that it's any better than anything else, but it does. She was in quite a lot of pain with this. This was painful and interfering not just in just in normal activities, just moving around on the bench.
Yeah.
And so I'd be looking to do something that relatively quickly that will have some sort of pain relieving effect on this, so she can rehab these. Steroids might have a role in that sort of not emergency, but in that acute phase. But we generally discourage that. And but yes, I could quite see if it was less painful, I'd almost be more interested in it. I sometimes think.
I want to hear you. I'm sorry for interrupting.
No, steroid has a bad name, certainly in the UK for these, but it might have a role in it. But with something like this that's a bit idiopathic, not quite sure what's going on, I would be just a little bit more cautious, see if we can settle her down in some sort of more physiological way, which I think Shockwave represents, and take it from there.
I would like to talk to you briefly about, well, it doesn't have to be briefly, but the mechanism of nociceptive inhibition from shockwave therapy, or what is the reason that we have a reduction in afferent signals of pain? What I can get my head around fenestration. I can get my head around eruption of blood into a tendon. I can get my head around a number of things. I can even get my head around shockwave therapy if it's a little, meat tenderizer that's in there doing something like that. But am I not understanding that shock waves are using, in essence, sound waves to disrupt that material, and they're just kind of jostling around in a concert mosh pit, after which they then pull away and then the pain is better? Help me understand that.
I don't know. I have no idea. It is sound wave, but then so momentum is a sound wave. The sound waves are just momentum. So it is exactly like your hammer, your tenderizing hammer. The tenderizing hammer is essentially a sound wave.
Yeah.
So the physics is exactly the same.
The sound waves are supposed to also be the phacoemulsification, that they take hard lenses out inside of eyes, where they're taking the cataracts out. They go in there and they use this super high frequency thing that destroys it, like we're playing asteroids.
Yeah.
And it
the shockwave is the same as they use for lithotrips. We used to call it lithotrips.
Yeah. Where they're aiming three things to break up this crystalline structure. Yeah. But if you keep endorsing that shockwave thing, I'm going to have you send me one, with on the outside saying jerky or something like that, so that I can start using it on my patients. But you're not the only one. I've had some orthopedic surgeons reach out to me and say, would you be willing to work with us on imaging and doing that? Because I know in Canada, when I trained up in Vancouver, every one of those guys had a shockwave machine, and they said it marries really well to ultrasound.
Yeah, because you can use the focused shockwave. If you've got ultrasound, you can use the focused ultrasound, which is the more elegant of the types of shockwave, because you can know exactly what depth you're looking at, so you can do much more sophisticated treatment.
You need to start perfecting that, and then we'll design it.
I've not ever actually used it, but I've referred countless patients for it.
And you've had the feedback of it being positive from those patients, or?
By and large, yes. Like everything.
Yeah.
There is it's always a bit tricky to draw conclusions from your anecdotal experience, and we don't. One of the companies I work for does do some more sophisticated sort of audit analysis, and they rate it, but I can't quote the figures.
All right, I'm listening.
This is a trigger thumb.
Is that an enlarged hood that I'm looking at there, or well, yeah?
This is the A1 pulley.
Yeah.
In long axis, and this is the thickened flexor tendon.
When I saw it on short axis, I thought right there, that little blip is that anything that's inside the tendon that's of relevance?
It's relevant, but it's not a thing inside the tendon.
Right. That's just a
bit of anisotropy.
Okay, and it's as FDS and FDP do their little dance.
No, this is the thumb.
Oh, okay. So
this is, and that could well be a little bit of swelling inside it, but as it changes direction, and that's the thing to pick out is that difference in size. You see how the size of it as it goes through the pulley.
You're looking at the circumferential dimension.
Yes.
Okay, and the pulley is that dark color right there.
Yeah. So there's your pulley there.
Yes.
And the tendon is larger there than it is there.
Yes.
And actually slightly larger the other side. It's being pinched. It's stenosed, which is why this one doesn't trigger. It's just stiff. And that's what you go on to see when I go into long section. And that's me dragging the tendon through, and it just moves a small amount, and it just pulls on the thing.
That's beautiful.
Yeah. So you don't get, and if I showed you the other side, you just see it's rock through like this freely.
Yeah.
And that
So I want to see your hydrodilation or hydrodissection of this next.
I didn't. There, hang on. Here it goes. Trigger thumb injection.
Oh, good.
So it's a trigger thumb injection. So this is me. This is it. Slightly different frequency probe, just using the small probe. So the needle's coming in here just over the surface of the muscle. So I'm just trying to. What I don't want to do is go through that bit of muscle. So which is why it's a bit of a fiddly injection.
You don't want to do that because of pain or because of bleeding or because of what?
No, because they jump around like a frog in a box. If
like trigger point dry needling when they get them to quake or
they go ow.
Oh, you mean the patient does? You're not talking about. Yeah, I guess I don't know that. If you're into fascicular, you're into a much more nerve-rich environment.
Yeah, you stick a needle through. If you can avoid going through muscle, particularly through the small hand muscles, close to the fascial boundaries, particularly muscles, are very heavily innervated. So when you're doing shoulder joint injections, the patient really, if you don't go swiftly through some of those boundaries, then the patient really knows about it, leaps around. Whereas if you glide through them, you will do that. So yeah, on this thing, it's a bit of a slow one. So I shall grab hold of it. There you see me just getting past the edge of their muscle, which was good. And then it's there just dropping onto the top of the tendon. And then I'm injecting there, and then you'll see the fluid flow into the surround, hopefully. Go on, there you go. See it going in there.
Yes.
And just swelling up around it. And I'm not injecting at the level of, I'm injecting, that's it. So all down there. Oh yeah.
You're not injecting at the hood level or at the pulley level.
You don't inject at the pulley level. I used to do that. Not sure why. I'm just not very smart, I think. Because that's where it's stenosed. So it really is tight at that point, because that's the pathology. And so trying to get stuff in there is difficult.
You're not trying to affect any stretching, because like that could actually happen to an already enlarged pulley. You're just simply saying, look, I know there's a space that goes there. Why don't I do it where it's easy? And then you guys can worry about getting the juice there by gently moving your tendon around.
You got it in one. Yeah, exactly.
Okay. Interesting.
If you want to hydrodissect something, yeah, but you're not going to hydrodissect a pulley that can support your body weight when you're climbing.
That's right.
I think Eddie Murphy had an expression for that. It's like, get the fuck out of here.
That's right. Of course, what you should have is a picture of a person not able to move their thumb, and then you do the injection, and then afterward you can see them doing that, and then you could post that. And
it takes about 2 weeks for the steroid to work, so it's quite labor intensive.
Very good.
What did small Mortons?
I wished I knew. I wished I could be more confident with the Mortons. You have. Your short axis or your long axis between
this is long axis.
Okay.
And this is actually from above this one. So the bursa is superficial. There. So this is the Mortons there, or the slight swelling of the nerve. I'm afraid it's a short video, and there's the bits coming out. That's bursa there, I think, more. But that's probably a bit of Mortons, and this is from the other side now, and there, and just there's some nerve coming round here. So it was only a little clip, and just happened that the nerve is quite thick, quite obviously thickened. Not necessarily the largest Mortons you'll ever see. But,
what do you do? I've read saline. I've read a number of things that people do for that.
I just drop a little bit of steroid into that little pouch there, into that bit of that bursa, because there's the nerve, and there's the bursa. So I just drop a needle in here and just put a little bit of steroid, you know, 0.5 ml, half of it steroid, half of it local anesthetic. I just pop it in there. They seem to do quite nicely, but to be honest, unless they are genuinely painful, I don't bother. I just get them to get the orthotics right. I treat these quite conservatively because it's a mechanical problem generally, and I argue with the patients that, you know, if you don't address the underlying problem, it's just going to come back. And so I use the steroid as a pain management thing because it will calm it down generally, but you know, if you want to get it, if you want to make it go away, then you've got to sort your footwear out and find some way of maintaining the arch if that's necessary. If it's a collapsing arch, anterior arch issue rather than a tight shoe issue, then you've got to make sure that's right. And then and I sort of say to the patients, if you're not painful all the time with it, then it's getting irritated and then it's settling down. So if they can walk for 10, 15 minutes before it starts, I say all you're doing with the steroid is is interfering with the system that's working because you're irritating it and then your inflammatory process is calming it down. So why are you switching off the inflammatory system with a steroid? If you've got one that is just sore all the time, it doesn't give you any relief, then the inflammatory system is not working. So 3-fingered salute, which is your steroid, you know, Control Alt Delete.
I've got you. Now I'm with you. All right, a reset type thing to it.
Yeah, that's my justification for using a steroid.
Yeah,
is that, and that's why I argue quite strongly with my patients that I want to use it for those patients where you are in pain and almost without condition. You know, you've got a sore foot. Every time you put the foot to the floor, it's sore. You're not going to exercise. It's going to be sore whatever you do. I'll take that away with the steroid. If you're fine and you have to walk for half an hour to stir it up, then actually that system is working really well. You're doing something to irritate it. Your inflammatory process is telling you that and then sorting it out until the next time you do it.
So stop it. Figure a way to stop it.
and that then you don't use steroid because it doesn't help.
Yeah, you know, very cool.
Because as soon as steroid wears off, it's just going to start again because that's the nature of your pathology.
Now, in you injecting the bursa here as opposed to the actual neuroma, or do you stay away from neuroma because it's too painful and it's just the wrong place to put the steroid, or are you saying the bursa is the space-occupying problem? Let me take that out of the picture. What's the rationale for that?
No, none of the above, really. The neuromas are a lot smaller than people gave them credit for. So it's literally, they talk about the measurement there, but they're measuring the length of it. And that's all, that's nerve and perineural tissue. And you can dissect that out if you like with an injection. But, you know, I don't see the benefit of it. You're just going to damage the structures, to my mind. And if that's what you're trying to do with alcohol, or you'd use alcohol or something like that, or botulinum toxin or something like that. But you don't. So if we're using a steroid, then I want the steroid to sit in the tissue. I like it if it's slightly contained because it's quite aggressive and damaging to the fat. And I think the fat does a job in there. So you get fat atrophy with steroids. So I'm quite happy to just put it in this area here. It will have an anti-inflammatory effect that will affect the whole area. So it's going to calm down the area quite nicely, just being in there. And I don't particularly want to damage the nerve. The thickening of the nerve is largely fibrotic. So whatever I do with the steroid, I'm not going to make a huge difference to it from the steroid itself. Or if it does, that's an effect of the steroid locally. It's not going to be mechanically improved by that. And it's an awful lot more comfortable because you're just sticking it into a space that a fluid-filled sac already that's there, and it's contained. It doesn't fly around everywhere else. If you put it in the nerve, that sort of any sort of volume is just going to spread out to the soft tissues around there, which is going to damage the fat.
Makes perfect sense to me. Yeah, it's that I didn't think about it. I didn't have the data in my brain to think about it, but that rationale makes perfect sense.
So that's what we do with them. Well, that's what I do with them. I don't really know what other people get up to. This was a patient that turned up with with nothing at all. They'd had a sort of orange-sized swelling on their patellar tendon. You know, they had a swelling the size of an orange tendon. And he said, "Well, I fell on it, I think he said, and and it made my leg go all sore all the way down there, and now it's got completely better." And this was there's his patellar tendon there, and he's got this collapsed bursa.
Yeah.
So just a nice thin layer there, and you know, a bit of debris, a bit of fat in there, but it's gone away completely. So with nothing to do with that.
Why is there a hyperechoic line inside of that?
There's that little bright line, yeah.
Sorry, bright line.
Yeah. Sorry, that's it.
Yes, I understand. I'm pushing your button.
Yeah.
But what?
That bright line is the boundary between that, and boundaries are bright.
Yes. So it is a interface between the two tissue components of the bursa.
Yeah. Well, actually, it's the interface between the tissue and a tiny bit of fluid, because the tissue and the tissue would probably have a minimal line, but that's your interface line, I presume. And it might be that it's a little bit more solid, but that's what I think we're seeing there.
That's not in any way indicative of any type of a crystalline response, and those white things are not indicative of tophus or anything like that, tophi or anything like that.
I don't think so. I think that is just a boundary. You can actually see there where it's the angle changed, and it's cleared a little bit.
Yep. And that wouldn't be the case if it was interlaced with a crystalline echo or whatever.
I don't think so. And these sort of little fatty things, you'd expect to see something like that in a bursa that blew up. You know, little clumps of sort of fatty hypertrophy. But that was very calm structure.
That's valuable to me.
That was good. And I think this was so it's funny. I now think of de Quervain's as a trigger finger of sorts.
What is the structure under? Wow, I can certainly see that. What is that? What is that annular ligament-like thing that's holding it there? Just
that's the pulley on the radial styloid that holds the first compartment in place.
Well, what about that?
So that looks exactly like what you saw on the trigger thumb.
Absolutely, it certainly does. We have a superior and an inferior component to that. That's beautiful.
One of those, this was slightly unusual. Hang on, I'll grab hold of the cursor. Whoops, not hit the freeze button. Grab hold of the cursor and we'll go back to here. So this is, it's not slightly unusual. This is a solitary abductor pollicis longus. Now, normally they're usually paired to sometimes 3, 4, 5, 6, 7 sometimes, but
I had no idea.
This is usually multiple tendons.
Yeah.
If I see this, normally I expect them both to be abductor pollicis longus.
Yes.
And the brevis just to be a tiny fleck like that. In this case, that is a mildly swollen abductor pollicis longus. In this case, that is a very swollen extensor pollicis brevis. The interesting thing is, though, and what made this one a little bit more interesting, if I go down there, hang on, let's have a look. you come back here, that is a swollen brevis. That's the brevis. That's me doing the movement test on the brevis. So I'm just extending the thumb. No abduction.
So this is what you're now telling me is that there's a difference between testing one of those and the other. So
yes. When you test the extensor, that's what happened there. So the extensor was not stenosed. So it's moving freely through the pulley. Yeah.
Yes. And what are you doing to test that? You're just doing the flexion extension.
Yeah.
Okay. All right.
At the MCP joint.
Yes.
And then, hang on, did I do that first? First this is the abductor. And I'll run it because so I'll run it from the start. This is me testing the extensor, I think. Yeah, I'm trying to move it, and then I couldn't move it, so I went and moved the extensor. Oh, no, I didn't. I obviously didn't get a good enough clip. That bit at the start is me trying to move the extensor.
And it wouldn't move because it was adhesed, or at least it was too swollen. Yeah.
Yes, it was stenosed. So he has a stenosed abductor and a swollen but not stenosed extensor.
Wow. I think you just have to have a lot more data points in your brain to understand what you're saying, because the extensor, you went like this, and then the abductor you tested uniquely. It was more of a way and back.
Yes, you just get the finger. You're really moving the metacarpal.
You're moving the distal component.
Yeah, you move the distal component there.
Yes.
You move well, not the distal, the proximal phalanx, but
yes,
but flexion there.
Yes.
Moves the extensor brevis, and then you hold that still up straight, and then you just waggle the thing, and if you're scanning while you're doing that, which is obviously you've got two hands. It isn't that. It's a bit fiddly, but it's only a bit fiddly. It's not actually difficult.
You have to have the data points to be able to understand what you're doing and then apply it to a picture. And what you were saying is that your story of how this looks with multiple fingers in it, and the fact that you know that the one tendon is noticeably smaller in ratio, allows you to look at this and already say, this is what's happened. There's not a lot of you out there that even know what you're talking about.
Hopefully more than they used to be.
That's probably true.
Try to educate. and you say, does it? It probably didn't. I think I might just have injected this patient, or they might not have had an injection at all. I can't remember, but it's it may not change your management directly every time, but it does start to break down what you're trying to do with the patient. It very much explains to them, because they just feel the pain. You say, no, you've got restriction in this movement. That's because of this. And this movement is relatively free. That's there. And also it makes it real for them, because you can actually break down what's going on and show them what's going on and say, and then when you sell them the treatment for this, which is behavior modification, which is making sure that they're not overloading their wrist at acute angles of the wrist. So either pulled back and you're sort of typing when you stood up too high, or holding the baby up, or doing the gardening like this and spending all your time reaching around the roses, because that's the mechanics of it. There may be some genetic and physiological disposition, but all my patients have a good story for doing the papering or whatever it is that sets it off. They are cheese wiring that pulley.
I don't know what cheese. Cheese wiring is how you cut cheese.
Yes.
Oh, okay.
like you floss your teeth.
Yes. No, I understand.
When you work these pulleys at oblique angles, at steep angles, and then you work it hard, repeatedly, you're just like cheese wiring it.
That makes perfect sense.
Why do you think they thicken up like that? And then it's all a self-fulfilling prophecy. I think there are lots of other bits, but you wanted to look at some stuff.
Let me set it up for you really quick here, John. I need your eyes on a number of things, and I'm going to be vulnerable to actually let you see my scan. So let me say right up front.
I had a quick peek before you started.
So I need to have you understand the person we're going to be showing here, and I believe it's been. I mean, I don't think I can dump images that have any recognition on them whatsoever. But it doesn't make any difference. This person I know would be willing to show it. Yeah. Now I recognize we're dealing with a different machine than what you're used to.
Yeah.
And I'd love to have your feedback as critical as saying, will you quit rocking it back and forth here, or you're off by 15 degrees, or and what I want to get your input on is I'm trying to identify, the MRI said that there is a complete failure of the anterior component of the supraspinatus tendon. And
can't see that on the scan.
What's that?
I would be I'm quite surprised at that, because it isn't obvious on the scan.
So that's what I'm wanting to have your eye, because I took a gut punch on this one, because apparently the MRI came back and it was, because I said originally, that I felt that there was a partial tear, but that I said it was mostly intact. And I did see that I don't know, that line that shows some brightness coming up from the facet. But more than just whining about that, I really would like to have you give me your input to say, hey, Greg, I need to have a little slower movements here, and I need to have you delay and slow down here. And what I have are several examples of both long axis and short axis, and I'd love to have you talk through it as though you were saying, this is what I would do differently.
Okay, right. So we'll start with this one. So we'll start at the beginning. So here we go. Let's pause it. Let's grab it. Yeah, let's go it again. So yeah. So I do a lot of this rocking backwards and forwards, just slightly changing my angle, trying to change how I do it. What I don't do is I don't rock around like you're doing there.
You don't go to the infraspinatus, or what I think to be infraspinatus?
No. What I'm interested in is, in this view, let's see if we can go back. Let's see if we can find. What I'm interested in is this tucked to the side. So somewhere about there. If we stopped there. Here, somewhere around there.
Yes.
With the biceps in this position. If you imagine a Y, drawing a Y on there.
Yes.
Yeah. That is supraspinatus.
Yes.
You've got the leading edge here. You've got supraspinatus. The body of supraspinatus is here with the articular fibers here, all the stuff that we think about with the pulleys in and all sorts of things.
Yes.
All those more articular sides fibers that are not necessarily linear tendinous fibers. Okay, so you've got that divide there. So you've got the main thing here. This line here is the divide between supraspinatus and infraspinatus. Yeah?
Yeah.
There? You see that there?
Yes.
Goes like that. And somewhere in there, this bit in this plane, roughly, and
yes.
I'd want this bit horizontal. Just imagine a line drawn there. And I'd want that level. That's what I'm going for, because that gives you the best imaging of that bit. And as I go, if I'm more interested in this bit of the tendon, I'll angle it so that this is horizontal.
Yes.
And but in this shot, generally, I'm somewhere near that being horizontal, which is what you've almost got there. Okay, I'd just be slightly further around, tilted the probe slightly more, just slightly like that. So you're hitting this layer here, this surface here, at 90 degrees.
If you can back up, I think my fourth image in was another try at this same thing. Not in this one, but like right. Let's try that. Let's see whether or not I'm any better as to what you're looking for here.
Yeah, that's sort of the angle, and you're coming across. Yeah, that's really where we're at. But you see how you rock around?
Yeah, apparently that's caca. I need to stay away from that and wait till I get that from the posterior view, or what?
No. I scan it in exactly the same position, but when you're going backwards and forwards here, it's only those fibers that are in the direction you've got your probe. It's only those fibers that are perpendicular to the probe. So as you rock around, you're looking at the, if you're slicing like this through your orange.
Yes.
And you're then looking at fibers that are not only turned this way, but also coming.
Yes. Yeah. Okay.
So this is just mush.
Okay, so I think what you're saying is you need to reorient if you're going to be trying to take a look at the infraspinatus. You don't just use the same plane.
No.
You need to reorient.
You have to go back to the thing I said to you first time we did one of these. You have to make that mental step from you take supraspinatus out of the body, you dissect it out like the best butcher in the world, and you slap it on a plate.
Okay.
That's what you scan, like a side of salmon. Your side of salmon.
Yes.
The fish may be wriggling.
Yes.
But the way you scan it,
yes,
it's as if you virtually make that flat, and the probe just relates to the flat longitudinal axis of that structure, and that's what you do. And so when you look at infraspinatus, you throw that away. You throw away the supraspinatus.
Yes.
And then you orientate on that.
Yeah. I can do that. My next question goes back to the one you had before, and that is, at what time and what point do you scan proximal and distal? So we're actually short axis scanning, and then we move from the under the acromion out to where we don't have any more fibers.
When you're scanning this,
yes,
I make very, very small movements, but every time you go backwards and forwards, you should be altering the angle of the probe to the point where you get your perfect picture. Then, once you've got that, and you only have to really do it once, generally, once or twice. So it's just one or two movements until your tendon becomes nice and bright, the brightest, through and back again. Then, what you should be able to do is you should be able to roll the probe all the way, very slowly, so that you encompass the whole of the tendon, ideally in one sweep. It doesn't have to be, but you only come back when you get a little bit of anisotropy.
You only come back to reorient when you get that, or?
Yeah, when you're bright, and then the image quality falls off because of slice thickness or anisotropy. You think of it as an anisotropy, but it's actually slice thickness. You get a slight blurring of the picture, and then you come back to where it's good. You reorientate so it's perfect, and then you're trying to. So what you should do is every time you move, you should roll the probe slightly.
Okay.
So your movement is like this. So you're like a satellite going over the world, keep pointing down with gravity. That's what you're trying to get. And what you want to do is, while you're scanning, you'll be adjusting backwards and forwards to perfect it, perhaps. But when you're trying to, you should come through once. And if you're saving it, what you want to do is be able to save that all the way through. So if I'm looking at it, I want to see that ideally perfect or almost perfect roll until the structure disappears. This business back when we talked about scanning the patellar tendon, that you go all the way through to the outs to beyond it. You have to go to where it's gone away and then come back through it. And that's what you capture. So it's yours still, those images, those slides are a little bit frenetic. You're kind of going and then moving to the side. Yeah. No, you just think, I'm in short axis of supraspinatus. Yeah. Or I'm in short axis of the front of supraspinatus. And then you go, perfect. Yeah.
Take me back to, I just need to listen to your brain. I've got you for just about 13 more minutes and I'll quit talking. I would rather you just randomly say what irritates you so that I could, and I would also like to have some things that I can improve. I can clearly improve on infraspinatus and supraspinatus, and I could try to make that clear, but now I'm going to listen.
This is good. You know, you're coming in, you're looking at it. You come a little bit slower. I remember once really early, well, halfway through my training, when the sonographer I was training with brought in an old radiologist, and we'd said we wanted to look at an aorta, and I thought he would just plonk the probe on, go like we do, push down, and then no, he put it down, he stopped, he waited, allowed the picture to settle, if that means anything to you, just orientate himself, and then he moved really slowly through the structure, and I watched him, and I thought, yeah, now I know what's going on there.
Because
frenetically going through.
Yeah, that's me, man.
But I saw him do that, and that was like a sort of light bulb moment to say, yeah, stop, slow, let your brain, let the tissue bend, and the rest of it, and then just make the picture right, and then just move slowly through it.
I can do that.
And that gives you time to recognize the changes. So as you're scanning through one of these, let me just grab that and bring it back. If I switch that off so I can pull it around. So as you're scanning through, the picture quality is changing. You're getting in and out of your optimum picture. You can see the lines fading and things.
Yes.
If you're going slower, you would recognize that and start to move.
Okay.
When I'm looking at a sonographer working, and I'm watching them do something, and I will see a part of the picture change. And what happens, the more experienced they are, the quicker they are to adjust for it. Hello.
Hi, Greg.
Is that my friend Juliet, or is that Beth? I can tell that that's Juliet.
No.
That's Beth.
Yeah, Beth with the hair tied up.
Hi, Beth. Welcome back from Cubs. Did you learn something new today?
What did you do? She can't remember. It was 5 minutes ago.
To be honest, the Rolo freshened my memory, so
Rolo.
Yeah, I had the Rolo Easter egg.
It's a sweet. Go on. I want to talk, so close the door. Yeah. Right. Yes. So yes, it's you're not taking. You're letting.
We'll be slowing down.
You're letting the picture change.
Yes.
As you're scanning, and you're letting so you've got one good angle, and then you're not changing it as you move backwards and forwards because you haven't got time to. So you need to slow it down and just creep. And I would practice that, just on one view, just go through. I'm just going to go and I'm going to see if I can. And what you'll find is that your hand will start to predict, because that's what you want to do, is get it so that you're not seeing the picture change and changing it. Eventually you're thinking, in your head's telling you it will change that way. So that's what it would do. These are really useful because they're not bad scans. Let's take a look at the long section. I was quite impressed with this. I'm struggling to see a full thickness tear here. There is something going on at the leading edge there, at least on this view, and you've got an effusion in the. Did you see the effusion in the bursa?
Yeah.
So that's just an effusion in the bursa going down the side. Again, you're interrogating. It's a little bit uncertain, but here it doesn't look like there's anything as you approach the biceps there.
Yes.
Come back. There's something gone on here, but I can't. But it's.
Now, when you say you can't, is it because my technique didn't slow enough and refine the?
No, I just don't think there's the information there. It doesn't look like a full thickness tear, but there is something going on there. So if we go back to your short axis, and we thought this was probably a good one. There's certainly no full thickness tear there, and that's where the disadvantage is because you haven't gone carefully through to slowly through onto the insertion. Yes. There might be a full thickness defect. We don't get a good quality picture there, though that's still pretty good there, that bit. And this dark area here looks like anisotropy, but as I say, it's difficult because it's anisotropic to be able to say with any certainty.
Yeah. When you would get that, when you would get there on your slow scan, you would then just alter that beam angle enough to be able to assure that it is, because it's what do they call that? What is that rope? I forget the word that they call that, and the cable. That's what it is. The cable. A cable would not be able to be refined like the fibers if it was just the lower fibers of the infraspinatus. Not in this plane, would it?
Well, the cable can come up here, and when you see it, I'll have to dig out a scan for you at some stage where that shows the cable just running over the biceps. So it runs nicely over the biceps.
It goes along with the CHL. I mean, it's like it goes up over.
There's a lot of blending of the CHL with it. I don't know where. Yeah, you're not seeing it here, but this bundle of fibers here that runs along the bottom.
Yeah.
We're at the level of the cable. It just sweeps nicely over the biceps like this.
Okay.
Yeah. Okay. Can you go into the other? Can you go into the other room though? Sorry, there's a bit of.
Okay. I can let you go, John. I really value this. I may make myself more vulnerable for you to take a look at my scans because I need to hear that. Anyway, I'll let you go. Tell hi to the family.
Will do. See you later. Send me some more pictures like this, though.
Okay. You'll be able to see me get better, I hope. All right. Yeah. Talk to you later.
Cheers. Bye-bye.
Bye-bye.